Good afternoon, everybody, and good morning, and at different time zones. We're about to start the pre-BSACI WAO meeting webinar. I am George Gkimpas, and I will be co-hosting this meeting today. I'm a consultant allergist and the BSACI lead for the annual BSACI WAO meeting. I will be co-hosting this webinar today with my good friend, Bryan. Bryan, would you kindly introduce yourself?
I am Bryan Martin. I'm the president-elect of the World Allergy Organization and co-chair for this World Allergy Organization BSACI meeting. I'm currently a professor of medicine at The Ohio State University in Columbus, Ohio in the United States, and the chief of allergy there. Back to you, George.
Thank you very much, Bryan. So the World Allergy Organization meeting hasn't been had here in the UK for about 40 years now. So that's a very long time. And this today, what we are doing this year in 2022 is a very important thing. After 40 years, we are again hosting the WAO meeting with BSACI. Obviously, this had to do in the midst of, we had to do that in the midst of a pandemic, which is not the best of luck, obviously. But I'm very pleased to say that BSACI had also organized the first, one of the first face-to-face meetings of a large scientific society last year at 2021. And it was met with an astonishing success. So I'm very confident that we have all the expertise and the experience that we need to ensure that this meeting is also exceedingly successful. I am also pleased to note that coronavirus appears to be going away now, and most restrictions are being dropped, as you might have already been informed. So you will certainly receive more emails as we go closer to the meeting, letting you know that Edinburgh is open for business, and we are all expecting and waiting to see you there. I'm very pleased that we have managed to prepare a very engaging, a very exciting program with worldwide speakers, with speakers of global caliber coming from all over the world, and most of them, the vast majority of them, will indeed be face-to-face to present at this meeting. Some of the speakers have very kindly offered to be here today with us and makes some of their presentation actually part of the presentation, so that we will all know what to expect from this meeting, and we will all know and understand the quality of the talks that we are to expect. So I am very pleased to give the floor to Bryan so that he can introduce the first speaker.
Thanks, George. Our first speaker is Dr. Motohiro Ebisawa. And Dr. Ebisawa comes to us from Japan, where he is currently the president of the World Allergy Organization and director of the Clinical Research Center for Allergy and Rheumatology of the National Hospital Organization at the Segamihara National Hospital. He's a leading expert on food allergies, particularly in Japan. He has published over 200 papers on focusing on food allergy. And today what he'll talk to us about is oral immunotherapy for food allergy in Japan. Dr. Ebisawa.
Giving me the opportunity to talk on oral immunotherapy in Japan. My name is Motohiro Ebisawa from Segamihara National Hospital in Japan. This is my COI disclosures. We have previously reported the pediatric allergy immunology in Japan in the year of 2013. In that review article, we reported that among 514 pediatric training facilities by Japanese Society of Pediatrics, there are 312 facilities routinely performing oral food challenges in Japan. Among these, there were already 53 facilities performing oral immunotherapy at the end of 2011. That was already more than 10 years ago. Treating 1,400 cases of food allergy. We performed another survey on OIT in the year of 2015 and reported on our official international journal, that is Allergy International, in 2018. In the survey, we mailed questionnaires to training facilities of Japan Pediatric Societies from July to August 2015. The questionnaire requested information on the implementation of OIT by the end of March 2015. The first questionnaire was sent to 524 training facilities by Japanese pediatric societies. The first survey requested information on the implementation of OIT, whereas the second survey aimed to gather more detailed information on OIT, such as its safety. In total, 360 facilities, 69% of them, responded to the survey. Among them, 102, 20% provided the information. We defined inpatient OIT as treatment provided while the patient was hospitalized, although the patient could have been subsequently followed up in outpatient clinics. In contrast, shown on the right side panel, OIT, outpatient OIT was defined as treatment and followed up provided without hospitalization. In total, 973 patients were treated with inpatient and OIT, outpatient OIT. The number of patients treated for allergens is shown on this slide. Egg followed by milk was the most often used allergen in each OIT, used in 552 and 554 for egg and cow's milk in inpatient OIT, and 3,223 patients for hen's egg and 1,849 patients for cow's milk, respectively. Regarding the treatment stage for OIT, 75% of inpatient OIT patients and 62 of outpatient OIT patients reached to the target dose during the survey period, and 456 patients, 6%, dropped out. The number of patients that received OIT was different for each facility. 63% of the facilities provided OIT for less than 50 patients, whereas only 5 facilities provided OIT for over 400 patients. So there were big difference among the facilities. The median follow-up period was 4 years in inpatient OIT and 3 years in outpatient OIT. During OIT, most OIT facilities reported patients who had immediate allergic reactions requiring treatment. In inpatient OIT, allergic reactions occurred in hospitals in 1,055 patients and at home in 863 patients. In contrast, only 691 patients receiving outpatient OIT developed allergic reactions. The frequency of immediate allergic reaction in inpatient OIT was higher than that in outpatient OIT at home. Wheat followed by cow's milk was most common triggers in inpatient OIT, whereas egg followed by cow's milk, and wheat was the most common triggers in outpatient OIT. In inpatient OIT, 132 patients required adrenaline injections when hospitalized, and 85 patients required it at home. In contrast, adrenaline was administered to 54 patients in outpatient OIT. A total of 139 patients required adrenaline injections at home. Regarding milk, wheat, use of adrenaline injection in inpatient OIT was higher than that for outpatient OIT at home. This is my final slide. In order to improve the efficacy and safety, I'm going to talk at these 3 points at WAO BSA Joint Congress in April. Thank you very much for your attention.
Okay, thank you very much. This was the talk by Professor Motohiro. Unfortunately, right now in Japan, where Professor Motohiro is very early in the morning, so he will not be able to be today with us for Q&A. I want to note that questions, you can submit your questions throughout the presentations or while you are seeing the video in between, and we will discuss all your questions at the end with the speakers who are able to attend. I believe all speakers apart from Professor Motohiro will be here to discuss any of your questions. Now, before introducing the second speaker, I would like to see a video. I would like everybody to see a video of Edinburgh. Edinburgh is beautiful throughout all seasons, and we are very lucky to be able to have this meeting there. And I'm sure everybody will enjoy their time there. So if we may. Thank you very much. And this is Edinburgh, and we are all looking forward to seeing you there. I would like now to introduce Professor Graham Roberts, who will deliver the second talk. Professor Roberts is a professor and honorary consultant pediatrician in pediatric allergy and respiratory medicine at the University of Southampton. He is the president of BSACI and has very significant research work with a worldwide impact. He will talk us today about food allergy, and he will tell us how he would manage a young person with food allergy. Graham, you have the floor.
Thank you very much. It's great to be here at this webinar, and hopefully you're all enjoying it. So if we can start with my slides. In Edinburgh, I'm going to be talking about the systems approach to managing food allergy and all the parts that actually we need to think about. And I thought I'd give you a little bit of a taster of that. But the way I'm going to give you a taster is to focus on young people. And if we just press the next one, Ben. By young people, I also mean young adults. And I'm a pediatrician, so I see patients up to about 18 years of age. But my understanding from my adult colleagues is young adults have exactly the same challenges and probably will be amenable to exactly the same interventions. So if we go forward, yes, all young adults, and forward again, please. So, okay, so I'm going to just very briefly talk about a systems approach, then I'm going to dive into why young people and young adults behave in the way they do, and then talk about a few things that potentially you could do to make their lives easier, improve their outcome measures around food allergy, and then finish off with a few conclusions. So next slide. So this is a sort of systems approach. And if we can just click forward a few then. So there are lots of things actually are really important in terms of minimizing the likelihood that your patient is going to experience an allergic reaction and they're going to maintain good quality of life. Remembering actually that you can never get risk down to zero with food allergy. There's always a degree of risk. So if we can go forward once more. So primary care. So a lot of this work happens in allergy clinics, but actually if you've got a good primary care setup, I think actually a lot of these patients can be dealt with, the low risk ones, and a lot of the follow-up training can be delivered. So you have a click again, Ben. So the aim here is to reduce the chance of ingestion, recognize allergic reactions earlier, and actually make sure that the right self-management steps are coming into effect. And that involves us as healthcare professionals. It also involved the allergy organizations. And they're very helpful in terms of delivering information and many ways delivering training. But you have to impact on your patient to make sure actually they're self-managing correctly. But there are two other factors, and if we just click forward twice, Ben, two other factors are the emergency medical services need to be competent around recognition and treatment of allergic reactions. And it's absolutely critical that food labeling and communication more generally in the food industry is sufficient to make sure that there's a minimal chance that your patient is going to ingest the triggering allergen for them. So if we can go to the next slide. So why do young people behave in the way they do? And there's many reasons for this. I guess the biggest issue that we all have with young people and young adults is they forget stuff. And if we just click through a few times, Ben. So why do they forget things? Well, the answer is there's far too many things going on in their life. They've got to develop new relationships, and probably with the opposite sex, negotiate new rules at home. They test boundaries continually, including around their illness, their long-term condition. They've got to take responsibility. They've got to gain independence and get a job. There's loads of things going on, and actually food allergy may be quite low because actually the last time they had a reaction to a food was when they were infants, and they haven't had one since because their parents have been keeping them away from the trigger. Even worse, they probably eaten lots of products that say may contain without any problems. So from their point of view, they don't think they've got a food allergy. And we as professionals may have forgotten to talk about things, train them, and introduce key cofactors like alcohol, etc. And of course, they want to behave, they want to be seen as their peers. They don't want to be seen to be carrying a long thing with a needle in called an auto-injector. They might actually also be needlephobic. So there's lots of things to explain why they behave like they behave. So if we go to the next slide, please. So I think in terms of adherence, it's useful to think about in terms of barriers and facilitators. So barriers are things that you want to remove. And facilitators are things you want to try and action lever to actually improve the management, the self-management of your patient and improve their outcomes. So if you click once more, Ben. So what are the potential levers for change? So I think education is key here. So you get a young person, age 11, 12, they might have been in your clinic for 10, 11, 12 years, but I can guarantee that most of the education will have been directed at their parents, probably their mother. And actually, they may well not have actually received much specific education for them. And that needs to be dealt with as soon as they get to an age where they need to be doing things themselves. And you've got to think practically. So I have conversations about, okay, so you're going shopping, you're getting in some new clothes. What sort of clothes could you buy which would actually accommodate 2 auto-injectors? In other words, the pockets need to be fairly large. Inside pocket or jacket works great. Obviously a bag if you're going to carry that around. The other key thing is to get their action plan onto their phone. If they take a picture of it, you can guarantee next time they're out and about and having a reaction, they will have access to that action plan. And if you get into trouble, you need a psychologist friend, and sort of cognitive behavioral therapy is very helpful here. But actually the other thing I use is sort of motivational interviewing type approaches that can really engage, and hopefully then you can get them doing the necessary steps of self-management. So if we go to the next slide, so we talked about adherence, so let's now talk about self-management. And a lot of the challenges overlap here. So again, it's lack of knowledge, but also their beliefs. And I've talked about why your teenage patients or your young adults may actually not believe that they've really got food allergy. There can be a motivational issue because of they're more focused on other things. They're not terribly good at self-advocating, and certainly they don't want to take responsibility because they've got too many other things going on, and there's emotional overlay here. So if you then click once more, Ben, thank you. So there are key levers though you can use to affect change, and I've already talked about education. I mean, one really helpful approach here is actually just to give the young person, young adult a scenario. They're out with their friends in a bar, there's alcohol, etc. They start to feel discomfort in their mouth, bit of swelling, etc., etc., and get them to tell you how they would actually manage that scenario. Real practical terms which might actually happen to them in the near future, unfortunately. But young people listen to older teenagers much more than us as health professionals or their parents. And I think one thing that we need to try and somehow do is actually lever that. And obviously you can't have an older teenager in your clinic doing the education, but videos of older teenagers, maybe talking to younger teenagers, talking about how to manage, I think might be quite useful. And there are 2 other things that we do in Southampton where we get a problematical teenager who doesn't believe they have got a food allergy and not happy we're not happy that actually they're going to manage it successful. And we use something called a demonstration challenge where we're pretty sure they're going to react, but we start the challenge, we start very low, we slowly go up. Inevitably they have a reaction. Sometimes they end up having to use an auto-injector, but them using the auto-injector on themselves in the ward is a very, very powerful bit of training. And our patients universally love this, and they feel a lot more confident afterwards. We have occasionally got them to practice with an out-of-date, an in-date auto-injector on themselves, but actually practicing with a dummy or an out-of-date auto-injector on a piece of fruit is also helpful. So if we go forward another slide. So the other lever you got here are supportive relationships, and these are families. And parents like to take a step back with young people, and their step back can mean that actually all responsibility is given to the young person, and that's a bad thing. So the parents need to, yes, step back slowly, gradual transfer of responsibility, but they have to carry on being supportive. Now, your other friends here are peers and friends of the patient. And if you can, that's where the strong relationships are forming, and they're really good at actually supporting their friends. And if you get into real problems with a young person or a young adult, try and get them to bring one of their friends along to clinic. Train the friend, because next time they're out, the friend will peer pressure them into doing the right thing. And then, of course, there's us as healthcare professionals. And I guess the really important thing is you have to engage the young person as your patient. Stop talking to the mother, talk to the young patient, and preferably see them on their own doing some of the consultation. So then if we go to my last slide, so a bit of a summary. And if I can just get you to click through a few more times, Ben. So what are we doing? This is a picture from our BSACI adolescent guideline. So one more click, perfect. Adolescent guideline published a couple of years ago. And things I want to emphasize are at this age group, young adults, young people, identify the misunderstandings, train them, make sure they know what they're doing, train them to actually self-manage and involve the family, involve their peers. And there's lots can be done to really impact positively on outcome measures for young people with food allergy. And as I say, young adults have exactly the same challenges, and approaching them in the same way is really helpful. Thank you.
Thank you very much, Graham. Thank you very much for this excellent presentation. It is always challenging, the association of young adults and food allergy, isn't it? And it is always important to talk about it and know what to do. So we are certainly looking forward in to your talk at the meeting about all this. So what we are going to see today, right now, before our next presentation, is we're going to see a video about some facts about the meeting, so that we will know what is happening, we will know what to expect, we will know what is the Ben, if you may. Now, after this video, I'm very pleased to introduce the next speaker. The next speaker is Professor Stephen Durham. Professor Stephen Durham is a consultant in Royal Brompton Hospital and a professional of allergy and respiratory medicine, the clinical lead for allergy services at the Royal Brompton Hospital, and the head of the Allergy and Clinical Immunology section within the National Heart and Lung Institute. His research interests include mechanism of immune tolerance in allergy and mechanism and treatment of allergic rhinitis and severe asthma. Professor Durham, during the meeting, will talk about immunotherapy, and today he will indeed also talk about immunotherapy to us as a taster of his speak to come. Unfortunately, he was not able to be here right now live, but he has pre-recorded his talk. So if we can play it, Ben.
I'd like to thank Dr. Gkimpas for the opportunity to give an opening talk for the BSACI WAO conference. My topic is allergen immunotherapy, what's new? Here are my conflicts of interests, organizational interests, research grants, and some consultancies with manufacturers of allergy vaccines. So what's new? I want to address 3 points. First of all, recent data confirming that pollen sublingual immunotherapy has long-term benefits. Secondly, the fact that house dust mite immunotherapy is now being incorporated in GINA guidelines on the basis of evidence. And thirdly, a novel approach using passive immunotherapy, both in the context of cat allergy and also allergy to birch pollen. So first of all, pollen sublingual immunotherapy long-term benefits. This is the big advantage of immunotherapy over pharmacotherapy, that we see long-term benefits after discontinuation of treatment. And I'd like to just highlight no less than 4 phase 3 trials that confirm this. First of all, the 2 original studies on grass pollen, one using the single species flown potentially grass pollen tablet, and secondly, one using a 5-grass tablet. And these were double-blind placebo-controlled trials over 5 years, 3 years of which were on treatment and 2 years following discontinuation of treatment. And we have here the seasonal combined symptom medication scores on the vertical axis and the data for years 1, 2, and 3. And you can see that both treatments were highly effective. Now, when the treatment was discontinued over a period of 2 years, double-blind, both studies showed continued benefit with effect sizes approximately 25 to 40% persisting over 2 years following withdrawal of treatment. And this, I think, was really very important. First of all, for the first 1-grass tablet, and secondly, for the 5-grass tablet, independent vaccines showing the same effect over a period of 5 years. Now, since then, there have been 2 further studies that I'd like to draw to your attention. One, I think, a very exciting study that comes from Japan, and this is the Japanese CEDAR study. Again, exactly the same design. You'll see there are 1,000 patients in this trial from Japan, and 3 years on treatment and 2 years off treatment. The effect size is between 30 and 45%, and this effect size over placebo persists for 2 years after discontinuation of treatment. This was in children and adults and adolescents. And finally, the so-called GAP trial using the single fast-dissolving grass pollen tablet in 5 to 12-year-olds, which showed that over a period of 3 years, there was good efficacy for rhinoconjunctivitis. And then over a period of a further 2 years, this effect was persisted. So the message here is doubt no more. Using medication sublingual immunotherapy of proven value, we can be sure that long-term benefit persists for 2 years after discontinuation of treatment. And this is reflected in international guidelines, which recommends a minimum of 3 years continuous treatment with allergen immunotherapy as a disease-modifying treatment. So that is, I think, very, very important for for allergy sufferers and also for immunotherapy. Secondly, what about asthma? This is the trial from Christian Virchow and colleagues that showed, I think, convincingly that during a steroid withdrawal study, a phase 2b study, immunotherapy with house dust mite tablets was effective at reducing asthma exacerbations. The study was published in JAMA a couple of years ago now, and what we can see here is it was a dose response study, a dose ranging study with 2 doses of house dust mite versus placebo. There was a period of screening followed by 6 months on treatment in which patients were monitored with primary outcome, symptoms exacerbation and symptoms scores and asthma exacerbations. And then over a period of 6 months, there was a withdrawal phase whereby inhaled corticosteroids were initially reduced over 3 months by 50% and then withdrawn completely. And you can see there were 250-300 patients per group. And the results are shown on this slide for the primary endpoint. This is the 6 months during the withdrawal phase 50% reduction in steroids, 100% reduction in inhaled corticosteroids. And what we see here is a marked reduction in asthma exacerbations of around 30 to 35%. And this was true both for the 2 doses that were employed. Now, as a consequence of this, the GINA international guidelines have incorporated house dust mite sublingual tablet immunotherapy as an alternative add-on treatment at step 2 and 3, which is wholly appropriate. So this is the GINA guideline for adults and adolescents. You can see from step 1 to step 5. This is the most recent evaluation where it's encouraged to take either intranasal corticosteroids or combination therapy very early on in treatment. And what we see here is that quite correctly in relation to the data that was produced, that SLIT house dust mite tablet is an add-on at step 2 or step 3 of the guidelines in patients on either low dose maintenance or low dose combination treatment. So I think that that is an important piece of information. And thirdly, a really exciting recent development. This is not for long-term benefit. We're talking about an antibody treatment here. Robert Cook showed in 1935 that he could passively transfer protection against ragweed allergy using serum, post-immunotherapy serum, to block the intracutaneous skin test to ragweed. And there's a really, I think, important study published by Orengo and colleagues in Nature Communications a couple of years ago that showed using 2 high affinity antibodies directed against the dominant allergen of house dust mite, and the binding sites of these 2 antibodies are shown here. A single intravenous injection of 600 milligrams in some 70 patients. This was a double-blind placebo-controlled trial, and a single injection of these combination, this cocktail of antibodies, was highly effective at suppressing the nasal response to antigen challenge using cat allergen. And interestingly, this effect persisted out for 87 days. And when Dr. Shamji and colleagues looked at, this is looking at the visual analog scale, we can see here that there was a very close parallel in terms of pharmacodynamics. This is the concentration of the antibodies in the serum going up, and then of these 2 separate antibodies and coming down to around about 5 milligrams per liter at 85 days. And this is the data I've just shown you, showing the clinical benefit. And this benefit was really quite remarkable, because we had some 70% of patients at 1 week were showing a greater than 50% reduction in the size of the early nasal challenge result as detected by VAS, or total nasal symptom score. And this marked benefit persisted out for 85 days from a single tablet, a single injection. And this was reflected in the blocking antibody that was detectable in serum and nasal fluid. This is a study by Dr. Shamji in our group at Imperial College. And you can see a marked reduction here in the blocking antibody, both in serum and nasal fluid. And it was also reflected in a decrease in type 2 cytokines in nasal fluid, and a marked reduction in basophil activation when in vitro, when FeLD1 was, when human basophils in cat allergics were challenged with FeLD1. And you can see here the 2 antibodies independently and the cocktail showing a dramatic suppression of basophil activation. Now, what is very interesting is, and this is absolutely new data published this month by Philip Gervart and colleagues, is that this has been reproduced in the birch pollen system. So we have a very similar design here of a single injection of a cocktail of high affinity antibodies directed against the BETV1 major allergen of birch pollen. And you can see here, this was a 900 milligram single dose, and then the patients were followed up over a period of 3 months. And there's a very similar effect size here. Nasal challenge was the primary outcome, and you see a very marked reduction in the nasal response to birch pollen. This is persisting out for a period of 2 months with this study after a single injection of 900 milligrams. And then we see here a marked suppression in the immediate skin test, the IgE-dependent immediate skin test, which is persisting out to 3 months. So in 2 systems, FeLD1 neutralizing antibodies using a single dose was effective at 1 week and persisted for 12 weeks. In the BET-V1 system, birch pollen allergy, again, a single dose was effective at 1 week and persisted here for a period of 8 weeks minimum. And then the work from Dr. Shamji and colleagues showing that the mechanism involves blocking of both high affinity IgE and also low affinity IgE receptor dependent events and suppressing Th2 in the effects in the target organ. So I hope I've convinced you that allergen immunotherapy is in a strong place. We have cast iron evidence for long-term benefits. We have an indication for asthma in international guidelines, and passive immunotherapy is the new guy on the block. And clearly, we're waiting for some phase 3 trials. Thank you for your attention.
I want to thank Professor Durham for this excellent presentation. Unfortunately, he was not able to be with us here live, so it was recorded, but it was no less interesting. This was just a taster from what Professor Durham is going to present at the meeting. He will talk about allergy modification, delivery, and passive immunotherapy without allergens. And this will be just one out of a number of talks about immunotherapy that will also include allergen plus approaches for immunotherapy, and indeed talks about SLEET as mainstream management, as there was a question about that. So we are very much focusing on immunotherapy, and there will be quite a few things to discuss and see at the meeting for immunotherapy. I'm very pleased now to go to the next video, where we will see about an overview of the program of the meeting, what to expect from social activities, and generally what people can see and find and live in Edinburgh. Ben, you have the floor.
Thank you very much for that excellent overview. Our next speaker will be Dr. Luciana Tanno. And Dr. Tanno is currently a member of the World Allergy Organization Board of Directors. She did her medical training in Brazil, but is currently working in France. And what's important is that Dr. Tanno has held a number of important international positions, but time is short, and I will highlight only 2. And the first is she has been absolutely instrumental in our junior members program for the World Allergy Organization. She helped found the junior members, and she remains as an advisor to that group. So she's very involved in the organization of our junior members. But probably more importantly for everybody worldwide, since 2014, she has served as the co-chair of the Allergy Immunology Working Group of the World Health Organization's ICD-11 review group. So her work in this area has led to the allergic and hypersensitivity chapter in ICD-11. And before ICD-11, allergic diseases were not well represented. And so she has worked tirelessly to make sure that allergic diseases are highlighted in ICD-11. And her talk today will be on the impact of globalization in the management of anaphylaxis. Dr. Tanno.
Thank you very much, Bryan, for this kind of introduction. I'd like to thank both of you, Bryan and George, for the invitation to be part of this webinar. What is a kind of strategy in order to seduce you, my friends, to be part of this meeting. I hope we will meet in person now. So I will talk about the globalization and management of anaphylaxis, but in fact, I will not talk specifically directly to the anaphylaxis because I will talk about this during the meeting. So my presentation, in fact, will be mostly an introduction, what we have been doing in terms of globalization and medicine, allergy, and so on. So, sorry. So, the definition of globalization, we do know that is the interaction and integration among people and governments and companies worldwide. So we do know that these interactions started for a long time, reason why we had all the colonization history and so on. And the fact is that since the 80s, when the internet has been implemented worldwide and the airplanes and aircrafts had been traveling all around the world in a very faster and easier manner, we have now a huge interaction, and the world now is becoming very small, because the idea is that we would not be able to talk to each other, for example, in this webinar, without this globalization. And due to this globalization, we have been advancing in many tools, such as global social media and other international tools. And nowadays, we do know that, for example, the cell phones and computers are mainly part of our bodies. We do not live without them. And how it's expected to have the impact of this globalization in health. Needless to say, the example of the COVID pandemic we are living now is a little bit better, but it was a devastating and astonishing experience all the world had. We started with some little cases in China in December 2019, and after a few days, weeks, it spread. We had a dramatic situation with many cases of hospitalization and deaths. And now, with the due to the vaccination and other measures, we have been reducing the number of cases. But it's not just only about the COVID. You know that IBM has launched a program, the Watson Health, and what is estimated is the average person is able to generate 1 million of gigabytes of health-related data in their lifetime. It's amazing, isn't it? Because in generally speaking, we are now talking about big data and health, and how we can manage this in clinical practice. What's the importance of this in clinical practice? I will talk about this in my presentation in April. I will not go deeper now on this, although it's really, really amazing and interesting, but it's just to trigger some discussion with you regarding how it impacts in terms of allergy. We do know that we are living now an allergy epidemic. Allergic conditions have been increasing worldwide, not only in numbers, but in complexity. What is challenging for us in clinical practice in the daily clinic? However, what's most important is that we are expected to have 50% of the whole population in a few years being allergic, and 8% presenting anaphylaxis, near fatal anaphylaxis, what's really, really dangerous. So reason why it's really important to have the data collected and analyzed and provided to the health care institutes. So, and what about our academies? We do know that our academies have never, ever been able to settle down if we were not in the ages of globalization. We know that the American Academy and the American College were the ones who were engaged
Hello?
so the Latin America Society and the Asian Pacific. And for example, I would say that for WAO, it would never be possible to have this federation of allergy, asthma, and clinical immunology societies without the globalization. And for anaphylaxis, what's going on about the representation of anaphylaxis? I had a brief search of the term anaphylaxis in PubMed and see what we have, a very huge increase of a number of publications over the last 10 years. It means that anaphylaxis has been a great issue in clinical practice and a topic of interest, not just from clinicians, but from researchers and public health managers as well. So the idea is that since the first description of anaphylaxis in 1902, yes, we have a birthday here, completing 112 years. And the implementation of the adrenaline as a key treatment of anaphylaxis later on, and the implementation of the auto-injectors to save lives. We had a lot of things to do. So I will discuss all the issues and benefits of the globalization in terms of anaphylaxis in the April presentation. I hope seeing you there, and we will discuss how we will get better in this the management of anaphylaxis. However, we have been doing well. For example, in WAO, we have launched in last year the World Allergy Week with the topic anaphylaxis. Be aware, be prepared, save lives. What was a very successful initiative in order to increase the awareness of this condition worldwide, as well as we have producing many papers in order to advise healthcare professionals, and of course it's not only the World Allergy Organization papers. We have many others in which we have been contributed, such as the most of anaphylaxis guidelines, and even worse now, what we have been facing is the personal history of anaphylaxis due to vaccines. So it's a brief flavor of what I will discuss with you in my presentation on April. And more than that, the idea is understand what we had, what we did right or wrong, what the current status, and what we expected to the near future. So I will finish my presentation saying, see you soon. Thank you.
Hello.
Thank you, Luciana.
Thank you very much, Luciana, for this excellent presentation. We're looking forward to seeing your presentations there. We're looking forward to seeing your presentations at the meeting. I actually believe you have 2 talks to give at the meeting. So we sure wanted to get a taste of this, and now we're looking forward to this. Now, we have some time for questions, but there are a few questions here, and most of them have been already answered. I can see that there was a question about accommodation, and you can check out the site, and there are a number of options there where you can stay. There's a question about sleep, and we have already addressed that, and indeed we have quite a few immunotherapy data to present. And other than that, I can see some technical questions that I'm not really the best person to ask and answer. I think I will go straight forward now to talk just a bit about the meeting before we close. I want to say that this was indeed a global meeting. This is indeed a preparation we did for a global meeting. We have heavily focused on collaborations worldwide. We have prepared several joint sessions. One is with the European Academy of Allergy and Clinical Immunology, where we are going to be discussing ENT issues. One with the American Academy of Allergy, Asthma and Immunology, where we will focus on immunology, clinical immunology, and the Japanese Society of Allergology, where we will focus on atopic dermatitis. So this is not only BSACI and WAO, we have included a number of other societies so that we can focus more on our worldwide collaborations, reflecting the importance of this international input. We will also again underscore allergy education and equality, diversity, and inclusivity, which sit at the very top of the BSACI priorities. There will also be a very strong focus on the environment, climate, and of course, given where we are right now, viruses, infections, and other environmental exposures. So this is just a taste of the meeting to come. We have prepared an exciting program, and we expect to deliver it in an engaging environment for all of you. So I want to thank everybody for being here on behalf of myself, Bryan, and the BSACI and WAO. I want to thank you, and I want to tell you that we are all looking forward to seeing you at Edinburgh, and we're looking forward to enjoying this meeting with you. I need to stress that the early bird registration closes in about 11 days on the 18th of March. So there is still some time, but not much, to get the better rates for your registration. So by all means, feel free to go to the site and register as soon as you can. And we're looking forward to seeing everybody here. And before we close, I want to thank again Graham, Luciana for being here, and of course Motohiro and Stephen for recording these meetings, even though they were not able to attend at this time. And certainly Bryan, who is my co-chair, not only at this webinar, but also at the meeting, and has done a fantastic work, as everybody else has, in this WAO and BSACI collaboration. So thanks everybody, and I'm looking forward to seeing you at Edinburgh.